Okay, I'll make a start. So, hi everyone. My name is Neil Ranasinghe. God, I couldn't even pronounce my own name right because I'm feeling a bit nervous. Anyway, so I'm the moderator for today. This is the first of 3 SIOP sessions for London Global Cancer Week. I am a parent of a survivor of childhood leukemia. I'm a patient advocate and I've been involved in the Global Mapping Programme since 2018. Today, you're going to hear from several stakeholders and people that have been involved in the programme for a few years on how this programme is improving survival and helping children with cancer. And if you've got any questions, please put them in the chat and we'll either answer the questions after each presenter or at the end. The Global Mapping Programme. So what is it? The idea is we're mapping every institution in the world that treats children with cancer. What? So this is questions like, does the hospital have radiotherapy? Who pays for treatment? Is it the government or the parents? How many children are treated in hospital? This is questions about the workforce, nurses, nurse to patient ratio. How many paediatric oncologists are there? The where, which is an obvious question, where exactly is the institution? And how do we get this data? So in some cases, it was 10 questions we asked to the people at the hospital. And in other places, we're asking considerably more. And you'll hear from Amita in a minute and how they've done things slightly different in India. So we started in 2018. It's now 2026. We're not at 100%, but we are at 100 countries. So far we've got 100 countries and we've got 685 institutions. And as you'll hear, we're also in negotiations with Russia, China, North America, and Europe. So very soon we're going to have many more than 100 countries mapped. And in the spirit of London Global Cancer Week, it really is a meaningful relationship between SIOP and the institutions and the regions that are doing this work. So the data is owned by the institution that provides the data, and it's not just for publishing papers. It really is helping improve treatment for children with cancer and helping survival, and it's enabling research. So now we're going to hear from some of the other people that have been involved in this program for a long time. So the first person is, so I'm just getting my slide, is Maite Gorostegui. She's a paediatric oncologist working at the Paediatric Cancer Center in Barcelona. She's passionate about improving access to high quality care. She is actively involved in educational activities, head of training at her center and medical director of the Telio program. And since 2023, she has volunteered in the role of chair for this group. Over to you, Maite.
Thank you, Neil. Thank you to London Global Cancer Week for having us. Today we have, I think, a representative for every continent. Only Oceania is missing today, but we will talk about them. So it's a pleasure to share with you how we are moving from data collection to action. Let me just move here. Here. So this is an overview of the SIOP Global Mapping Programme. You can see how we have identified institutions in Latin America, in Africa. Here you see our current mapping in Asia and how also Oceania has started. As Neil mentioned, it's not only that we have the location of every facility, we are collecting data about the essential care of the children. We haven't done this alone. We have achieved this with the help of many. I can the list is long, but I want to thank to the presidential continent of each SIOP branch, and like Gebor Tamamian that is not today with us, and organizations, colleagues, everybody's helping, because this is a mapping that belongs to us, to the pediatric oncology community. And now we are entering a very promising phase. And why is that? This is because at the beginning we were just collecting the data, then we start realizing how we can use them to understand better the tremendous heterogeneity that we have worldwide in pediatric oncology. And now we are seeing how people is getting interested in this data and how we can build new projects. So I would like to mention to you two points: highlight the workforce and the educational gaps that we are identifying to realize how important is this. Because if you look in the literature, our workforce, the people that is working in pediatric oncology, is a complex workforce, and it needs to be complete because it impacts directly on survival. And educational gaps are related also to the workforce. And if we can also intervene on education, of course, we will impact the workforce. So collecting the data, we have seen how the workforce in pediatric oncology across the continent is not enough. It's not enough, the number of nurses, the time that they have. It's not enough, the number of pediatric oncologists. It's not enough, the number of surgeons that are really trained in pediatric oncology and can solve the tumors problem. So there is a lot to do, and with the numbers on the table, it's easier to find solutions. We know that global mapping has become a tool for research, and we can discuss later. And I think Dr. Guillermo Chantada will explain this point, because it's a tremendous help, it's a tremendous source of information for advocacy. We, as I said before, we can understand better the tremendous heterogeneity that we are facing in pediatric oncology. So from collecting data to the action, we do simple things, and also we are dreaming like a big project. We know that it's important that we talk with the local leaders, with local people, because every region is facing their own challenges. And we are adapting also the mapping. We are asking questions that we didn't ask at the beginning. So everyone can adapt the mapping, and the mapping can grow from a baseline to wherever you need and you think is important to help the children. So we have had meetings, and this is a thing that we continue to do with leaders from China, from Russia. Jennifer Gill can also explain how she joined the local people in the workshop in SIOP Africa. So we talk with the people that is really, really involved to work together. We are starting new projects, and for us we are really proud to share with you that we are about to start a mapping the survivorship units and the resources. This is a big project that it's taking part with people from the University of Seattle, with Pediatric Cancer Children Barcelona, with PAHO, with SLAUP in Latin America, and I hope we will have fruit soon. We also have a project trying to help the inequalities about the central venous lines access. The surgeons are also very active, and they are working in Latin America trying to expand the map, taking into account the surgical oncology needs. We have also received ideas to start a new project with PAHO, mapping the psycho-oncological support. Liliana can also comment. And the reality is that new people are approaching us with new ideas and things that maybe we thought were important, but at the end we began with the basic, with essential things. But now this is growing, and this is growing very, very fast because everybody is interested in the project, and I think is seeing the relevance and the power of mapping. So this is what I wanted to share with you today. I think we can comment later, but the reality is that we have moved from data collection. The collection still is ongoing, but we have moved to action because in parallel, things are happening because everybody wants to start helping the children now and not tomorrow. Thank you, Neil.
Thank you, Mikey. Right, I'm now going to try and share a slide and talk at the same time, which is going to be quite tricky for me. Right, so next up, we've got Amita. Right, sorry. Right.
Yeah.
Can everyone see Amita's slide?
I can.
Right, okay. Hold on. Right, so now we have Amita Trehan. Amita is a professor of Paediatric Hematology Oncology at the Postgraduate Institute of Medical Education and Research in Chandigarh, India. She has been involved in paediatric hematology and oncology for 25 years and has been active in research and teaching. At present, she is involved in research in a multinational trial for leukemia and also exploring the genomic landscape of relapse. And she's passionate about developing supportive care in India. Okay, over to you, Amita.
Okay, thank you so much, and good morning and good afternoon to everybody. And thanks to Neil for handling the technical glitch with my slides. So we mapped India. Maite has already given the background of the mapping. So I think we all know that India, we have a lot of unique characteristics as all countries do. So at the moment, we are the most populous country, a very diverse nation, geographically, economically, and culturally. And we have a healthcare system which reflects wide disparities in resource availability, accessibility, and cost of care. Now, this applies to the pediatric oncology services as well, where there is diversity across regions, and it is a mix of all types, public, private, and non-governmental organizations. So if you look at oncology services in India, they started in the 60s. Now, the last 2 decades have witnessed hematology oncology fellowship training come into being and an increase in the number of centers across the country. And the last decade has seen a spiraling of collaborative research amongst all the major centers of the country. An analysis done about a couple of years ago by the Indian Council of Medical Research across all centers showed that services were concentrated at tertiary hospital for oncology, and private and non-government run or trust-run hospitals were better resourced than public ones. Less than 50% hospitals had trained pediatric oncologists, and there was a shortage of nurses, diagnostic beds, and infrastructure. So the mapping which we did was, of course, SIOP with residents and the Pediatric Hematology Oncology chapter in the country. And this was envisaged in about 2002 by the bearers of the Pediatric Hematology Oncology chapter of the country. It was initially based on the questions, which are the SIOP 10 core questions, which has been adopted by WHO GICC also. So when we made the initial form, we thought we should do a little more based on the levels of care in SIOP. So it was 45 questions, subsequently modified to 55. We piloted it to 11 centers. And then, because we were in contact with Resonance, which maintains and analyzes data, the questionnaire had to be refined because of the logistics of the platform and to ensure the core content of the program, which took a while. And finally, we had it ready in December 23, and it turned out to be a little exhaustive 93-question survey. So this was emailed to all the members of the Hematology Oncology Society in the country, follow up with repeated reminders, after which the ones in our country did personal phone calls, and we got technical support from Resonance to sort out any issues people had in answering the survey. So this we did the data collection from nearly a year, and in November, December of 24, we closed from answering the survey and then went on to the analysis. So now, when we've had a few more responses after this, which we've not analyzed, but about 89 responses were available in March 25, right? So if we look, there's a larger number of private sector oncology centers compared to public center in the country. And the type of centers, the dark green shows that it is mainly the oncology centers where pediatrics are treated, and a small percentage some are the multi-specialty centers. Very few are pediatric centers, just less. And the distributing across the centers is like the healthcare across the country. It's better in the southern part, vis-a-vis north, south, east, and west. Predominantly, it's nearly half were simple general hospitals, which treated oncology. The rest, a small number of university hospitals, medical schools, and oncology centers were the rest. So going on, when we saw that if you looked at the new patients in every center, it was about varied from 5 to 2,000, which is obviously dependent on the size of the center and whether it was a public or private center. And number of beds per center was just about 15. 40% expressed bed shortage. Emergency care was available nearly everywhere. 2/3 of center had a dedicated chemotherapy area with a biosafety cabinet in hardly half of them. And most centers had daycare services, though most centers shared the daycare with adults. So going on, we had that after analyzing further, if you look at the facilities available, most of the in charge, the medical personnel were there. There was a trained medical personnel who was in charge of your unit in most centers. A full-time consultant was available in just about 1.8 consultant in every center, which obviously compared to the population is quite low. And unfortunately for us, adult oncologists were involved in about 50% centers. The nursing scenario was also a little unsad. We realized only 25% had oncology training. Most functioned on experience in oncology nursing. And the nurse to patient ratio, of course, was not good, 1:5. And 2/3 of nurses had to rotate to other areas, which meant non-pediatric oncology areas. So the subspecialty availability was there in barely 44% in-house. So they either relied on a subspecialist in the city or else probably in the city. A pediatric anesthetist was there in only 50%. Surgeons were available in all, but very few had oncosurgeons. Radiologists were there in most centers, as were radiation oncologists. PICU services were available in just 46% centers. And if you look at services in centers, about 67 of 89, which is about 80%, had a pediatric ward. ER services having a full ER room dedicated to pediatrics was there in about 60%. Most had a daycare. Multidisciplinary meetings were held in most centers, and I've already said in-house specialists were limited. Okay, if we look at supportive care services, most had a hospital infection control committee. Blood products was available in nearly all, but in-house was less. They were outsourced from the city, from another blood bank in the city. Most had a social worker. Nutritionists were there, but a pediatric nutritionist was there in only 40%. Onco-pharmacists were very minimal. Palliative care again was there in about 65%. And psychosocial support and physiotherapy services again were not there in all, but about 2/3. There was hardly any availability of a bereavement counselor, a bare 20%. Okay. And then we look at the lab supports. Routine diagnostics, which includes your pathology and biochemistry services, was there round the clock in more than 80% centers. However, if we look at radiology, sorry, Neil, this is animated. Could you just click, please? Radiology, the CT scan availability was there. MRI and PET CT was available it declined. And specialized investigations like methotrexate levels were there in about 84%, catecholamine levels in just 1/3. And the last bit, in-house availability of all these tests was just in 20% of the centers seen, mainly being outsourced, which was a large number to commercial labs and some to the specialized hospitals in the city. So what did we learn? What did the mapping tell us? I think the private sectors had more PCUs than the public sectors. Public sector was mainly in the university hospitals. It's very urban centric. The rural areas are very underserved. If we look at the mapping on the map of the country, there is an absolute shortage of trained staff. And still, despite now being 2025, a lot of centers, adult oncologies look after pediatrics. Subspecialist support is available again in less than 50%. And in-house lab services is there in just hardly 20% centers. So there is definite service disparities existing in pediatric care. And obviously, these disparities negatively affect the quality of care being delivered, which brings us to the urgent need to strengthen all the services available, supportive and specialist expertise. So I have acknowledged everyone who has helped, with a special thanks to Emin and Neeta, who have been my partners in crime in troubling people to fill the survey, and Jennifer and Chandan from Resonance, who have really worked very hard to get people to complete the form in the proper manner. So as Maite says, that soon this mapping will help us improve. And thank you so much for the opportunity to present this and do the mapping and give our results to all of you. Thank you so much.
Thank you, Amita. Neil, we have a quick question from the chat. I will just ask to Amita because it's really something that is quick. They're asking us why some colleagues, people was refusing to join the mapping in India. If you can explain us.
Okay, yeah. So what happened was that some hospitals said that it had to go through their ethical committees. And some hospitals felt that they did not. This was actually, to be honest, more of the private sector hospitals rather than the university hospitals. Some hospitals did not want their data to be on the map. So the pediatrician there told us that they're sorry, they cannot do it because their hospital, the dean or the administrative side of the hospital He was refusing to let them fill it up. So we were also very surprised because we did not expect anybody to refuse. And of course, just very few, 3, 4 people have the time to fill it up.
Great, thank you, Amita, for your presentation and for answering that question. So now we have Dr. Guillermo Chandada. He's the past president of SIOP and the head of the outreach program at the Hospital St. Joan de Diu, Barcelona, and scientific director at the Hemato-Oncology service at the Hospital Pereira Rosell in Montevideo, Uruguay.
Thank you very much, Neil. Should I share my slide, or it's in the slide desk?
Can you share?
Sure. Okay, here I am. Just thank you for once again. Thank you for the opportunity on sharing with you just a reflection on how we can use global mapping data for informing policy. And I just have one slide, but this is a very busy slide. So this is a slide that we obtained from the Latin American experience. And we published that in the literature last year. So I just put this slide just for you to see the complexity of the data that we could get with only 10 questions, because we can then link this information, these responses, to data that we have from the country. For example, the income level, the estimated pediatric oncology cancers that are expected in each country. Importantly, how many patients are seen in public centers and how many patients are seen in a referral centers, and how many patients are seen in low volume centers as well in the country. Also, we can estimate the number of new patients according to the number of pediatric oncologists we know because of the mapping there, and then cross-link that with the number of medical doctors that are in the country. That's a figure that is publicly available. So first of all, what you see here in the first column is how complete our data are. So as you see, for most of the countries, you see that we were able to have data from most of the centers in each country. Even in large countries like Brazil, there are 75 centers recognized by the authorities, and we have data from 64. But from many countries, we have almost everyone, like Colombia, like Argentina, like Ecuador, El Salvador. We have just one, but we have them all. Mexico. So the data we were able to achieve, thanks to the big effort of the Latin American community, it was really very big and representative. So what does this data showing us, and how can we use this data for public policy? First of all, that you see here in this column, that the number of patients seen as in public centers is roughly 80%. So first of all, the first message that this data gives us is that about 80% of the patients in Latin America are seen in public institutions. So that, of course, makes absolute sense with the current policy from the Pan American Health Organization to target governments, ministries of health, etc., because by that we will be targeting about 80% of the children, and probably including the most vulnerable. The other message that we get from this slide as well is that the care of the children with cancer in Latin America is heavily centralized. As you see here, these are each country has one or sometimes two centers of excellence or referral center, the name each country can provide. But as you see here, usually you see that 60%, 65%, 52%, even countries that they have just one center, but see what 100% of the patients. So roughly, we could tell from this data that 70 centers in the whole continent see about 2/3 of all the patients in the continent. So again, targeting only 70 centers, this is a very small number, especially for the adult oncology community. 70 centers are probably the number of centers we have in my neighborhood in adult oncology. 70 centers in the continent see 2/3 of the patients. So if you really want to make an impact in survival, in advocacy, in any topic, it's not just, but you just need to target 70 centers to make an impact. And another estimate that we could get from this data is about the workforce. There have been variable definitions on how many pediatric oncologists are needed for each of the new cases of pediatric cancer seen in different scenarios. There are data from Canada ranging from one pediatric oncologist every 15 new pediatric oncology cases. There are other recommendations from other groups saying that only 1 every 50 new cases could be the minimum that a country should target. So we were able to estimate this as well from the countries, from the data from global mapping. So now you see here that probably countries that we have high-income countries in Latin America, only 3, and upper middle-income countries have higher number of pediatric oncologists in the country. So they have one pediatric oncologist every 16 cases, like in Argentina, like in Uruguay, every 11 cases, or in the Dominican Republic every 12. But there are countries, probably the ones that have a lower gross national income. You see here that there's still a big need for pediatric oncologists in the region. So they have one pediatric oncologist every 40 new pediatric oncology cases, or countries like Ecuador, they have 1 in 51, or in El Salvador and Guatemala every 40. So they are still, or you see here Honduras, one pediatric oncologist every 63 cases. So that shows us that we still need to invest funding, money, to train pediatric oncology professionals in the continent. And again, that the continent is very diverse, that the countries that are doing differently than others. And if we look, you cannot see this from this data, but in the paper, we showed that, interestingly, the number of pediatric oncologists per patient, even in the countries that have very good figures, like Argentina, for example, is much lower, paradoxically, in the public centers, which are the centers of excellence. So still in these countries that you see that the average is good, probably they are not so well distributed. So, and that correlates, of course, with the number of medical doctors per 10,000 people in the country. Of course, there is a lack of doctors in the same countries that there is a lack of pediatric oncologists, but we still need to invest in our workforce. So, in a nutshell, just by collecting 10 questions and then crossing with the data that we have publicly available from this country, we are able to provide data that would eventually guide public policy at the continental level or at the national level. So thank you very much for this opportunity, Neil, and looking forward for the interaction. Thank you very much.
Great. Thank you. Thank you, Guillermo. It's really, really interesting to see how the data is used, and it didn't just pop out. It really has to be mined to see what's there. Okay, so now we've got Jennifer Gill, paediatric oncologist from Johannesburg, South Africa. She's the current president of SIOP Africa and one of the founding members of the SIOP Global Mapping Programme. Okay, over to you, Jennifer.
Thanks, Neil. Sorry, I'm just quickly sharing. So thank you very much for the introduction. And thanks to everyone for joining us here. It's really nice of the London Global Cancer Week to include us year on year. So a lot of, sorry, are you able to see, is it in presenter mode? Yes, there we go. So what I'm going to do is I'm just going to give you a very broad overview because the Global Mapping Programme started as a global effort, and then we decided to focus on Africa as the continent with the lowest survival rates that were documented and what we thought was the greatest need. So we started that process in 2018 and concluded in about 2021. So that data created a really nice baseline, but it's now quite outdated. So the current situation is that Africa is sitting with a big proportion of children with cancer in the world, and our survival rates are really not great. So there are various versions of this map, and it really hasn't improved much over the last, let's say, 5 years or more. The map on the right comes from a conference that I attended recently, and it doesn't really matter which conference it is, because you see a version of this map over and over again. So what it's depicting is all the people who are at the conference, where they came from. And all of these people are working on global consortia on multi-center research activities. And if I hadn't been at that conference, that's me, number one, down at the bottom there, Africa would have been almost entirely unrepresented. So there was one other person from Morocco at this conference, but it just shows that Africa is underrepresented on the world stage. And if we're not sitting at the table, we can't make a difference. So at the moment, there are about 1.5 billion people in Africa, and people in Africa always bleat that other people talk about Africa as though it's a country. But we ourselves often speak of ourselves as quite a homogenous group, and it's because we are quite unified in the challenges and also the desire to make a difference. So our population is growing, and it is a very young population. So by 2030, it's estimated that 1 in 4 people in the world will be African. So if a quarter of the world's people are sitting in Africa, and we're the continent with the lowest survival rates, there really is strong impetus to do something about that, to make a change. Currently, many estimates, but one of them is that about 37% of new childhood cancer cases occur in Africa, but this includes undiagnosed cases. So in our country, at least half are undiagnosed, and in many other countries, maybe 80% or more are undiagnosed. We're expected to overtake Asia and to account for more than 50% of the global childhood cancer burden by 2035. So that's a mere 10 years to come. So SIOP Africa has spent a lot of time, we've thought long and hard about what we can do to make a difference. And we've really adopted the Global Initiative for Childhood Cancer, which is a WHO initiative. And the big goal of the GICC is to improve survival to 60% or more in as many countries as possible. So if you're sitting in the UK and your child has like an average childhood cancer, not a weird and wonderful one, they generally have a very high chance of survival. So if you're sitting in a high-income country or a very well-resourced setting, 60% does not sound like a lot. But to people sitting in countries with very low or non-existent survival rates, this is an amazing goal to achieve. So the 5 pillars of our strategic plan are advocacy, education and training, research, data and monitoring, expanding membership, and strengthening and expanding strategic partnerships. So these are the main SIOP strategic goals as well. And we have added access to that because where our kids cannot access proper services. So how do you cure them if you can't even get them into the right hospital? So where does global mapping fit in? Well, it really helps us with advocacy. If we have good data, if we know where we're going, if it represents these specific countries, then we can use that to leverage better services country by country. Everything is about data now more than ever. So it fits into our strategic goal of research, data, and monitoring. And then because we've worked with various people over the years on global mapping, it's really helped us to strengthen and expand our strategic partnerships. So one of the things that we learned from the data capture of the continent was that there are probably about one, sorry, pediatric oncologist for every 600 new childhood cancer cases per year. So you've just heard Guillermo talk about the ideal of around about 1 in 15. Even if it's 1 in 50, we're speaking about logarithmic differences. It's impossible. It's unmanageable. It's unsustainable to work like this. And I used a pediatric oncologist as an example, but it's a pediatric oncology pharmacist. It's a rehab specialist. It's a nurse. It's a radiologist. It's all the people that we need to treat kids with cancer. All of them, we are grossly, grossly understaffed. Now, obviously, it's different in different countries, and in South Africa, we are relatively privileged, but we still don't have the staff we need. So far, global mapping has helped us to improve care, identifying the needs so that we can advocate for better services. We've started to engage with various stakeholders. This includes governments, providers, civil society. We really do have essential data. So as I said earlier, it's outdated and we're working on updating it. But what we want to do is focus on simple, high-impact questions. The most important thing is that this whole process has been Africa-led. So we're not led by outside funders or people with agendas that are not altruistic or don't necessarily meet our needs. It's very much an Africa-led process for us. So the next phase is to finalize a simplified survey, very similar to what Amita was talking about. We're going to launch that in 2026, and then we'll be devising a specific action plan so that, as Maite said, we can translate this data into action. Thank you, and I'm sorry for my voice, I'm getting sick again.
Thank you, Jennifer. It sounds like you're struggling a little bit. I hope you're okay. Right, so now we're on to Gevorg Tamamyan, an Armenian pediatric oncologist and hematologist. He is a professor and chairman of the Department of Hematology and Pediatric Oncology at Yerevan State Medical University. He's the CEO of the Immune Oncology Research Institute and editor-in-chief of OncoDaily. Over to you, Gevorg.
Thank you so much, Neil. Thank you very much for having me here, but you promised to ask the question.
The question. Shall I ask you the question now?
Yes, of course.
Right, okay. So, hold on a second. can't find the question.
No problem.
Oh yeah. So what? Sorry, I've got it. So
yeah,
what
no
do you
problem.
see? What do you see as the power of mapping childhood cancer treatment centres across Asia for key stakeholders, including parents, NGOs, government, and survivors?
First of all, I want to thank SIOP and Maite and yourself, Neil, for this and everyone there for having this global mapping project because I mean it's really important. As someone said very wisely, if we don't have data, I mean, we cannot tackle anything. So having this data is critically important, and having this mapping to know who are on the field and how the field basically looks like globally, it's very important. Now coming back to Asia and talking about the global mapping in Asia. Asia, as any, I mean, is as the other continents, but I think Asia is one of the most diverse continents globally. I mean, when you are talking about Asia, it starts like, let's say, where I'm sitting right now in Caucasus, and it goes up to Japan, Indonesia. So, I mean, and there you have all this diverse kind of, not only the populations, but also the systems, the different backgrounds, and having, I mean, and as we all know, one size does not fit all. So having this, all the information, it's critically important. The other part, as you mentioned, when we are usually, I mean, when the narrative is about talking about pediatric oncology, we mention just the pediatric oncology services, but it's a much broader scope. When we are talking about pediatric oncology, we need to talk about the NGOs you mentioned, about the infrastructure there, about the policies, about the patient organizations. So all this makes the whole infrastructure more complete. So, and here as well, the global mapping is critically important. I know that we encountered a lot of problems while the mapping was done. Although, I mean, it's really, I think, quite comprehensive, and still from some of the places we are missing some data, but I'm sure it's gonna come more. I think like the next steps for sure will come after this mapping, and it will help. As I mentioned, the area is very diverse, and through the SIOP we are working with every single country. Like we have. And tomorrow we are having our SIOP Asia board, and on the board we always discuss the different countries, and now we have this ambassadors program joining us. So it was critical to bring the representatives from the countries to bring in. But one thing is for sure, although we are all diverse, we have the same goals and we have the same missions. But by learning from each other, from this diversity, I think it brings much more results. I hope I was able to answer your question.
Fantastic, great, thank you. It's very interesting. Yeah, it's not just an exercise in publishing papers or whatever. It's really adding value. So we appreciate all the regional cooperation presidents of you helping out. Great, thank you very much.
Thank you, Neil. Thank you very much.
Okay, so now we've got our last presenter, Liliana Vasquez. She's currently working as a childhood cancer consultant in the Pan American Health Organization, PAHO, in the coordination of the WHO Global Initiative for Childhood Cancer, GICC. Additionally, she works as a principal investigator in the Precision Medicine Center of the Faculty of Medicine at the Universidad de San Martín de Porres. And thank you for getting up so early for this. And I think you might have all noticed that my Spanish isn't very good, is it? So over to you, Liliana.
Claro que sí. Muchas gracias. Thank you so much, Neil, and thank you, the SIOP and everyone, the SIOP mapping for the invitation to this event in the London Global Cancer Week. It's an honor to be here and to share a little bit on what is happening related to the mapping and how this is informing the JCC from the perspective of Latin America, of course, and the Pan American Health Organization. Very happy to be on behalf of PAHO as well here. So just briefly, I think also Jennifer was commenting on our common goal for the JCC, that is increasing the survival of these children and how we can move forward in this joint effort through the pillars of the cure all. The fourth pillar is the evaluation and monitoring, and it's one of the most important because the mapping, of course, is one of the tools that we have now, thanks to all the work that you are doing through the SIOP mapping in many continents and globally. It's amazing what we have seen in very short time. I remember in last year when it was launched in Latin America, led by Guillermo, by Andrea, Maite, of course, another team. And now to see what is happening in the world. But also, I think one of the key success of this is how easy it's for us to work with you, right? I think Maite is doing a great job, and our team, and Neil as an advocate as well. It makes really easy to work with you, and that's one of the most important things that I just wanted to acknowledge. This pillar, through the lens of the JCC, is basically trying to strengthen childhood cancer registries to use the monitoring and evaluation frameworks to invest in cancer research infrastructure and participate in collaborative efforts that we see. And I consider that the mapping, the SIOP mapping, is very much important because of the second and the third role, right? How it is integrating these frameworks with other frameworks that are already being used by the GCC and by many other initiatives, and how this is a collaboration, and we're articulating all these activities for having data and to inform national policies and global efforts. So I think it's something that should be acknowledged as well, and to congratulate all the teams that are working in this. In Latin America, we have a strategic plan that has been led by countries, but with the support of PAHOs and Jude, many other colleagues that are part of this work, and with the specific indicators that are related to the impact, with output indicators, without process indicators. But what is most important is that these indicators, or this monitoring and evaluation framework, is now trying to be more articulated of the work that the SIOP mapping is doing, with this approach of being inclusive to address all the needs of the multidisciplinary teams. I heard from many of my colleagues in many other continents that we do have important gaps, but the most, I think that it's very key to know what is the baseline, what is the data, and how we can improve from that. This is a slide that I also bring here because this is what we have been working on, this implementation and monitoring framework from the GACC in the region, taking advantage of all the experts in the region and also the work that has been done globally to classify this into domains, right? With the impact, what are the indicators that we need for diagnosis, for treatment, of health workforce, for registry and governance. And as you can see highlighted in yellow, the global mapping is informing us in at least 6 or 7 of these indicators, of these 25 or 26 indicators that we're working with. We will publish next year, and we'll all be invited as well with the update of the childhood cancer profiles in the region. There are 32 countries and territories in Latin America and the Caribbean, and this is an important review after more than 6 years of the implementation of the GACC. How are we doing from the baseline this very moment at in the journey towards 2030. But the Latin American SIOP mapping was an important milestone in the region. I think it is a tool that we are using now to drive regional actions, to get the data, and to, of course, inform national policies, regional policies, interventions, actions that we need to do now. This has been an important work led by many of my colleagues and friends, and now we're trying to build, because we really think that the work that you're doing with the data and with the methodology, basically, that has been done and replicated in other continents is so important. So now, also my dad was mentioning this, we are using this data and methodology to build, for example, a regional dashboard for childhood cancer indicators that will be published next year, hopefully at SIOP or SLAUP next year, and with the framework of the Cural Americas and the GACC. And this is important. This project is also being funded by My Child Matters and the Sanofi Foundation and Foundation S, trying to call everybody to the discussion, not only, of course, SIOP, but also the regional SLAUP, St. Jude, Hospital San Juan de Dios, Barcelona, many other colleagues that are very important stakeholders in childhood cancer for Latin America. Also, the mapping of childhood cancer survivorship programs in Latin America. This is an important work as well, led by Ana Isurieta from Hospital San Juan de Dios in Barcelona, that is trying to engage work like Jesus. And it is better sometimes social care in Latin America, because I think it was 2 or 3 years ago, we were trying to build some specific tailored region also, and her team in other countries too, also mapping what are the resources, what are the needs from countries in Latin America related to psychosocial care. So I think this is just a brief overview on what is happening. I just want to again to congratulate all the team, because I think one of the most important things that you're always open to the collaboration, and this is what we really appreciate from different parts of the world. Thank you so much.
Fantastic. Thank you, Liliana, and thank you for getting up so early. So I'm just going to do a very quick recap, but I was going to ask one question to Eric. I'm not sure if Eric's around. And I can see we're running out of time. There have been some interesting chats in the people have put in. So we've got email addresses so we can get back to you. So I'll just try. So I just want to thank everyone for, no, I'm going to recap first. So you can see the Global Mapping Programme is impacting a lot of people and a lot of organizations, institutions, oncologists. They're looking for this data, and the data is really helping them. And we've really grown a lot, and we've also learnt a lot. And it's come up today, how we operate in different regions, different countries is different. And we're tailoring the mapping to the local needs instead of just us saying, you need to do it in this way. So it is changing all the time, and it's progressing all the time. So I'll just finish up by saying a big thank you to Resonance. They're the backbone of the Global Mapping Programme. All our data is held securely on their service. Foundation S for their support in the data collection. Julia Challenor, she's not here at the moment, but she's a driving force in the committee and helped me a lot today. And finally, I'd like to say on 1 p.m. today, there's another SIOP session, which is about PARC, and that's how SIOP is supporting meaningful research into paediatric oncology in low and middle income countries. And on Thursday, there's the third SIOP session as part of London Global Cancer Week. And that's about paediatric oncology, rehabilitation, global realities in evolving healthcare landscape. And that's Thursday at 2 p.m. So I'd just like to say thank you very much. And see you,
Neil. Thank you very much.
next year
Thank
or
you.
sooner.
Thank you. Thank you. Bye-bye.
Oh, Eric,
Thank you so
Eric, are you
much.
still there? If you've got time,
Yeah, no, I was there. I was there.
Right, Eric, I was just wanting to ask
okay.
you, because you were involved in this at the very beginning. What do you think of things now and the future and how it's progressed?
Yeah, I don't know how much time I have, but first I want to say that Susan has been critical in this journey. And, the journey started a long time ago. In fact, I was reading a paper from Levin in 1999 about the mapping of radiotherapy service in Africa. And I was really, blown away and shocked by the data where 22 countries had radiation devices. And I went to the PODC and said, do we have the data for pediatric oncology? And the PODC committee was the Pediatric Oncology in Developing Countries. And they didn't have any data. They had some information from people who were attending SIOP. And at the same time, I was receiving emails from people who were in Ethiopia or in Uganda, and they were asking me opinion about the treatment of their brain tumor. And I became very humble and very careful with what I said, because I realized that they didn't have chemotherapy, they didn't have radiation, they didn't have access to MRI scan. So all this, I went back to the PODC and said, we need to have the data. And there was no real enthusiasm. So I say, I need to do something. I became SIOP president. And then I say, we need to work on the data. And that's where Susan helped me a lot. We went to the My Child Matter program. We got funding for this. And this was the beginning of a great initiative. Started with Africa. And Jennifer has been wonderful. Julia and yourself, Neil, it was fantastic. But eventually, in 2022, don't laugh, I retired from clinical activity and became increasingly involved, in fact, in many different activities, including now I'm the president-elect of the Franco-African Group of Pediatric Oncology. When I go to Africa and I talk to the minister, I use the global mapping. And I was in Dakar a few weeks ago, and I say, guys, there are 4 pediatric oncologists for 900 potential patients in the country. Only 300 are treated, but there are 600 who are hiding. We need many, many more, and you can use this as a tool, as a weapon. I use it in Ethiopia as well. I work a lot with them. And, all this is very important at every level. But I think we need to go even beyond this, because we know that some people do not have access to treatment. So what do? And they don't have access because they don't have the money. And we mentioned very quickly this. But should we also work on how to treat patients who have no money, but they want their child to be treated? I'm in China today, and I saw a family, and they say they had no treatment for chemotherapy. We say, perhaps we can use radiation for this child because it's much cheaper. So we need also to work beyond this and see how we can integrate the information we have into action plan and see that we have to adapt the protocol, but we have to adapt also to the social circumstance of the patient. So I think the global mapping is helping so much to do this and to move on and to make people aware that the 80% survival is only the top of the iceberg that we see in North America, in Europe, and in some of the countries. But we have really to work on what happens to the 90% of the kids who live outside this region. So thank you for giving me a few minutes to talk about this. I'm really fantastic. It's a fantastic initiative, and I thank you everyone for the passion, the work that we put into this. And I think we need, as a SIOP community, to be aware that this is a wonderful tool.
Great, thank you, Eric. Your contribution is always very interesting and relevant. Right, so we're 7 minutes over, and a lot of you have things to do. So I'm going to close this meeting now and thank all of you for attending and participating. Great. Thank you very much, everyone.
Thank you again.
Thank you, Neil.
Bye.
Thank you.
Thank you. Bye.
Bye-bye.
Bye.
Bye-bye.